Thank you so much, Judy. It's so nice to be here today. I'm Kate Davidson. I'm the director for the Learning and Diffusion Group, and I've been working with the LAN now for almost 5 years. It's been so wonderful to be out and get to see so many of you, and just a lot of warmth in the audience today. Over the last few years, I think that we've really done a lot of work with the LAN, but also under the leadership of this administration, to really right-size the focus away from payment for the sake of payment reform and adoption, but really focusing on patients and what's most important to them. Focusing on how do we accelerate the adoption of person-centered accountable care. We've made progress toward our goals with the LAN. We're really on that kind of cusp of moving from the most of the market into value-based care and really trying to move toward that 60% adoption rate across all lines of business into value-based care, and we'll talk more about that throughout the day. Where we really think we'll see momentum and movement toward the adoption of true population health management and person-centered accountable care. There's also real barriers, and I think we need to talk about them and address them today. But you'll hear, and Judy mentioned in her intro, a number of themes that will be echoed throughout the day. And the reason for that is because the LAN in the last few years, but especially in the last year, has really narrowed in and focused on a couple of things to really to center us and to ground us or anchor us in our work. And one is this idea that, again, payment is an enabler. True transformation and innovation happens within care delivery. And so as we think about payment, as we think about what are the edges around which we can try to create an opportunity for providers to really create and to think about improving the quality of care, we really think about wrapping a payment system around that care delivery model. We think about designing with the patient in mind. Thinking about what's most important, and you'll hear a little bit of that throughout the day as well, some guidance from our Perspectives Council around the things that are valuable to patients, such as affordability and access and experience. And then finally, we're thinking a lot about what's most important to providers. How do we simplify the payment models that we're trying to move folks into? We know that administrative burden is a real thing, and it is a barrier to folks moving into accountable care. And we want to see if there are ways that we can improve upon our infrastructure, try to streamline data and reporting, as well as quality measures and incentives. So with all of that in mind, I'm really excited to welcome our panel today. Number one, it's been a real honor and a pleasure to work under your leadership, John, who is the Principal Deputy Administrator and Chief Operating Officer at CMS. Mark, always a pleasure to work under your leadership with the LAN, who is one of our co-chairs and is the director of the Duke Margolis Health Policy Center. And then Alice Chen, who is also one of our co-chairs, and always fun to learn from her and from her leadership on the LAN, but also elsewhere, where she is the Chief Health Officer for Centene Corporation, which is the largest Medicaid managed care organization in the country. So with that, I'm going to cut to the chase and hear directly from the panelists. I'll start with you, John. CMS set a bold goal about in 2021, I believe, to have 100% of Medicare beneficiaries and the vast majority of Medicaid enrollees in an accountable relationship by 2030. Wondering if you could do a little bit of reflecting on what the progress has been toward making some of those goals and where you see the future of CMS in trying to achieve that.
Sure, Kate. Thank you for the question. Thank you for your work. Can you hear me? Or come on. There we go. Now can you hear me? All right. Kate, first and foremost, thank you for your work. Thank you for your leadership. And Judy, thank you for honoring Jeff's life. We were all very saddened to hear the news this week. I think to respond to your question, Kate, I think the first thing for us just to remember is the context when that goal was set. It was 2021. We were still in the midst of the worst pandemic in our history. The healthcare system was really struggling to recover, and the team set this goal not just to think about how to really restart the CMS work, but to really galvanize the healthcare system writ large and to give it some push, some direction. And I think one of the greatest accomplishments that I've seen today is that we're in a far different conversation than we were 2 years ago, 3 years ago, 4 years ago, that we're really talking about what is possible now and not just how we really struggle to recover. So I think the first accomplishment, one, is to define and set broad goals that the whole country now has responded to. And it's so gratifying to hear that it's not just the CMS team that's talking about this broad goal, but that it's being mirrored by health systems, by states, by other entities that are critical to success. I think that's the first accomplishment. Second is the work is hard. How we think about attribution models, how we think about risk adjustment systems, how we think about benchmarking, how we think about really integrating models together to create clear incentives. And so there has been tremendous progress, in my view, to really move forward to thinking about the really hard stuff that's still not perfected, but there has been tremendous progress. And I think the third piece that is really exciting is that we're finally at a point, and I give huge credit to our CMS team for this, of really driving towards a common measure set. And again, to the notion being that we have to simplify the models, we have to simplify the incentives, we have to really think better regarding the vocabulary that we use from the policy community to the healthcare delivery system. I think the third thing I would say is tremendous progress, tremendous credit, not just to the CMS team, but to the whole LAN itself, of really simplifying what we're trying to achieve, narrowing down, and coalescing to a common measure set. That has been to tremendous progress.
Thank you so much, John. I want to turn to you now, Mark. You guys have been very busy at Duke Margolis over the last few years. Number one, you've, I think, set a stake in the ground around multi-payer alignment by developing a multi-payer alignment framework. And you also have done a ton of work supporting the LAN, especially the strategic initiative around the state transformation collaboratives in North Carolina, but also more broadly. And I've been working with payers and providers across the country to think about how we do some of that simplification, how we approach multi-payer alignment. And so I was wondering if there are any reflections that you have about the momentum that is out there right now, about where some of the struggles may still be, but where the opportunity is as well.
Yeah, thanks, Kate. I'm going to build on some of the comments that John was just making about everything from risk adjustment to performance measures and the like, where we're getting to a more common understanding, effective measures, and ones that are consistent. And this is, by the way, where I think the LAN is so important. So there are a lot of activities underway, and appropriately so, to try to improve care, reduce costs, make healthcare work better for different kinds of patients, for different conditions, and the like. What the LAN has been very helpful in doing is providing a focal point to bring those groups together, not to replace them, but to help them leverage each other. And we're talking about Jeff Miklos's, he's a wonderful guy, great contributions to that effort through the Healthcare Transformation Task Force most recently. That's a collaborative effort that ended up partnering with the LAN on extending its reach to all of the Transformation Task Force members to inform the LAN's work through the work that it did. And that's a pretty common occurrence now. And getting back to this specific question, one of the things that people care most about in getting to accountable care implementation or value-based care, payment reform, and we can talk more about what all of that adds up to, is how is this affecting my care? And a first part of that is affordability and ease of getting care. And one of the things that we've seen the LAN help contribute to is getting to more standard approaches for the key components of making any kind of accountable or value-based care system work. Just like many of you are very used to working off a standard set of CPT codes, ICD-9 codes, all of those data standards for revenue cycle management, everything else that makes fee-for-service care work. Imagine if you were trying to do fee-for-service care with every plan having a different set of codes and the data standards that need to be provided and shared for just basic operations were different. When we started out implementing accountable care programs, we didn't have standards like that in place. We had the concept,
which is a really good concept, that healthcare providers and their patients, with the right supports, can probably come up with better ways of designing care models and spending resources on what really matters to patients. But that's been challenging to do. And over the last few years, we've seen, I think, increasing alignment on things like performance measures. If you're a primary care physician, I think we have some here, right, primary care folks? Probably, I think the average is more than 200 performance measures for things that matter to primary care patients that are really getting at a much more limited number of key concepts. So the Making Care Primary multi-payer initiative, which the LAN has been a focal point for advancing, has served as a vehicle for getting our health plans in North Carolina, getting plans in other states, getting national plans to see a path forward for how we can get to alignment, simplification, and compete on and deliver care with much less administrative burden. So that's a key step to affordability. The other thing that these standards, I think, are increasingly making possible is making it easier for providers and their patients to figure out where to go to get the best care at the lowest cost. So to inform choices, to help set up network relationships and collaborations between primary care providers and specialists. Kate, we're still in the midst of this journey, but it does seem like there's opportunity for acceleration. If you look at the tech changes behind this, we're getting to more interoperable standards for data exchange designed around, not fee-for-service, but designed around accountable care. Progress in AI, progress in analytics are also helping to advance this work. But the LAN has been very important in bringing together all these different pieces, all these different approaches. Everybody's flying their own plane, using their own standards at the same time, but we're seeing those converge.
I love that example around the CPT codes. I think it really brings that into focus around the quality measures and the need for simplification. I'm definitely going to steal that from you in the future, Mark, so thank you. Alice, I want to turn to you now. You have such an interesting vantage point. Centene is the largest Medicaid managed care organization in the country. And so you've got a lot of experience, both from a national lens, but also an experience like really getting to the community level. And I was wondering if you have any thoughts about what the themes that you're seeing from the national perspective, but also if you're seeing opportunities at the state and local level as well that you could talk about.
Absolutely. Am I on? Excellent. I'm on. First, I just wanted to express appreciation, Kate, for your leadership, John, yours, and Mark for your longtime leadership of LAN. Was really privileged to join you and Judy on the EF, and really appreciate having the opportunity to do some of this reflection. I think we've made a lot of progress and still have a lot to go. Thinking about state and localities, three things really come to mind. The first is around the work of our state transformation collaboratives. Anyone here from Arkansas? Excellent. Anybody here from North Carolina? I'm not seeing you. Oh, excellent. So, I mean, for example, some of these really exciting initiatives in Arkansas using the health information exchange to not only get real-time discharge data to PCPs, but actually make sure that the attending physician's name is there. So again, really making that linkage. So if the PCP has to track down information, knowing who to call. In North Carolina, the focus on health-related social needs, again, very, very person-centered. I think there's a lot of exciting work in the states that kind of bubbles up and that we can have a lot of cross-fertilization. As Centene, as a Medicaid plan, our teams have told me that there has not been a single RFP since 2016 that doesn't have a requirement around either APMs or value-based payments. So if that's not a strong signal that says that state Medicaid agencies are really thinking about how do we improve value, meaning access, affordability, patient experience, outcomes, I don't know what is. What's interesting is that states are also starting to think about moving beyond the traditional primary care and hospital realms to think who are really vulnerable members or residents of our state, behavioral health, LTSS, foster care. So APM frameworks and thinking about value has really started to percolate across the entirety of the Medicaid spectrum. And again, across states that are very blue and very red. When you look across every one of our 30 states, we're in 30 states, there is a common focus on improving value. The last thing I'd say is, as a health plan, really recognizing that people, patients, members live in communities, care and outcomes happens in the provider space, in the care delivery system, and in the communities. And that our job as a payer is to really partner with our providers, particularly those that have expertise in taking care of our most vulnerable patients. So we have a big initiative with community health centers across the country to figure out, there's a whole bell curve, but how do we figure out where different community health centers are? How do we start providing the education, the technical assistance, the capabilities to have them better manage population health and move up the value-based ladder?
Thank you, Alice. That really does bring into focus like this idea that all of the RFPs have been really asking for this movement to value-based care and Medicaid. I think that brings us a lot of hope and opportunity across the country.
Can I say one thing about that?
Yeah.
Which is that, lots of interest, and there's an opportunity in terms of standardizing what we mean by value-based care. Because again, HCPLAN framework has been wonderful in terms of creating a common nomenclature, a common way of thinking about payments, but people are calling everything from 2A on up value-based payments. And I think in some ways they are, but in many ways, when many people talk about value-based payments, they're thinking more shared savings, shared risk, like really significant alignment both on the quality and cost front between purchasers, payers, and delivery system. And I don't think if we stay in the 2A, 2B, 2C space that we're gonna necessarily get there.
So can I pull on that thread for just a second? And I'm going to turn to Mark a little bit because I think you've got a unique vantage point, again, based on your background too, as a provider yourself. And but pulling on this background around payment as an enabler for care delivery, as we think about what are we coalescing around, can you talk a little bit about this idea and this movement toward this shared vision for care delivery and how we use payment to enable that?
Yeah, I think since the early days of value-based care, or I'm not going to go through the terminology again like Alice did, we'll have plenty of chances to talk about how that's revised over the years. Everybody recognized that payment was important. Look, if you can't sustain a business model, whether you're nonprofit, for-profit, CHC, health plan, whatever, if you can't make the investments needed to change care and then maintain that on an ongoing basis, it's not going to work. And if your payments are all tied to fee-for-service and downstream complications and things like that, it's not going to work. When I had the privilege of being CMS administrator, which is a long time ago, we heard from healthcare providers, and they're like, look, we want to be paid differently, and we set up some of the early programs to do that, to change the payments. And what we've seen since then is that while the payments are necessary, they're not sufficient. And I do mean moving beyond 2A, for those of you who are into the lingo. You also have to have a lot of capabilities in your organization, ability to have a culture that's committed to the person, not just to delivering specific service well to people who come in the door, focusing on a person and the population. That means a change in the workforce. That means changes in the IT systems and analytics. Really changes in everything, changes in financing, et cetera, and getting these standards right too. And over the last couple of decades, we've been on this journey, not just to make quantitative progress in the payment reforms, but to make notable progress in the way people are getting care. There will be some announcements about that later today. Everybody with the land focuses on the survey, and it's really important. But I think what is really notable about these meetings that I see more and more around the country is the examples of how care models and care experiences for people have really fundamentally changed. And that does go along with bigger movements away from fee-for-service payment, to Alice's point. But it also goes along with understanding and building out these capabilities and standards, getting us from a fee-for-service infrastructure for healthcare and fee-for-service expectations and fee-for-service culture to one that really is focused on people and affordability and innovation to get them the best outcomes possible, and to address community issues and other things like that at the same time. It's really what healthcare should be about. We're still on that journey. John talked about, just one more point on this, how when he got there this time around for CMS, there were these goals set around getting everyone in Medicare into these kinds of relationships, having access to that, Medicaid and the rest of our health system as well. that built on a goal that the Trump 45 administration set in overseeing CMS and healthcare programs. We have to move away from fee-for-service and get to the money, the direct contracting or non-fee-for-service based payment, and the care delivery models where people can see the quality of care they're getting, the cost they're getting, and get those services delivered in a more coordinated way. So that administration to this administration, back 20 years, looking forward, this is an arc moving towards more comprehensive care and all the supports and culture changes around it. And it's really great to be here with this organization and so many people who are living and driving those changes.
Kate, can I jump in very briefly, because I am chagrined that I used all the jargon. I've been told, stop using all the jargon, so you can look up 2A, 2B, 2C. But the other reason I'm chagrined that I threw that out there without clarifying it is because sometimes I think while the framework has been really helpful, it does anchor people solely on the payment piece. So rather than really thinking about what are we actually trying to achieve, and I see that even in some of the RFPs and contracts, like we just want X% in this category without really thinking about, again, what end goal are we trying to achieve? And a colleague of mine had the best layperson's description of fee-for-service to value-based payments, which is fee-for-service is like just payment for noise. It can be 2 trash can lids banging together, or it could be a symphony or a pop song, whatever it is. Value-based care is you are defining what outcome you want, what kind of song you want, and it has to be at an affordable price. And so sometimes I think we lose track of what we're actually trying to accomplish when we just focus on the framework categories.
No, I think it's a great point. And even you get asked interesting questions about the LAN when people are looking at the agenda and stuff. And people are like, why are you doing the measurement panel last? Because we're really trying to focus in on what's most important here, what's most important to patients, to people, to families, to caregivers, to all of us that are trying to coalesce around moving us away from fee-for-service toward this vision for accountable care, person-centered accountable care. I am watching the time, and I want to make sure that we get to kind of what I think people are really interested in, which is this idea of where do you guys forecast us in the next, and where do you see the biggest opportunities in the next 5 years or so? And John, I'm going to end with you, if that's okay.
That's fine.
I'll start with Alice, and then we'll go down the line, if that makes sense to you guys, unless anybody has a different order that they'd like to go in.
Sure. A few things come to mind. One is Mark mentioned measurement alignment and measurement parsimony, and I think we've made great progress there. John, you mentioned it also. That was one of the, particularly in the primary care realm, really honing in on a few measures. I still think we have more work to do there, and I think we actually need to not just agree on it, but actually implement it. And I'll just reflect on, in California, the multi-purchaser alignment and the multi-payer alignment efforts that really I think are so critical to being able to create that administrative simplification for providers. I think a second piece I'm really excited about is, I mentioned North Carolina health-related social needs. I believe it was the Healthy Opportunities pilot that just showed, there was an initial evaluation that showed an $85 PMPM savings for those folks who did receive health-related social needs. And I think, again, from a whole person perspective, figuring out how do we responsibly target the needs of individuals from a healthcare and broader spectrum is going to be critical to improving the value of healthcare, particularly for low-income and vulnerable populations.
Just to build on that, the alignment on performance measures, as we've seen this take hold in North Carolina and other places, as you mentioned earlier, Arkansas, elsewhere, it's like moving on to, well, we also need a more consistent ways of sharing the data to identify people who are at risk and to be able to tell whether we're intervening effectively, and benchmarks, and we make those more predictable and consistent, and attribution. Again, it's all this core components for a value-based care system as opposed to a fee-for-service system. And with all of that, we've seen more progress. I think notable examples of some very strong advanced primary care models that are getting increasingly technology-enabled, that are getting out into communities, and I think there are going to be more even more digital and even more leveraging technology in the next few years. We've also started to see these kinds of models extend to specialty care. That's where most of the money is and where people need to get care in the most serious conditions. And that's been a bit lagging compared to primary, but again, more successful examples there. A lot of work by the LAN and by CMS and by innovative health plans and states around the country. So, and that also extends to the social drivers, really just the non-medical factors that affect how people use healthcare. So I expect to see more progress on all of this. And again, that's been kind of a steady arc, multiple administrations enabled by technology and really enabled by public-private collaborations like this one to help us all move ahead together.
Thanks, Mark. And so, John, I'll give you the last
word. Yeah.
But I want to also just say, one of the nice things that's been about working with you and under your leadership has just been how impressed I've been with how much you get out into the field and really try to understand what's happening in communities. I mean, to Alice's point and to Mark's points that they've been making throughout the morning, you really have an understanding of what's happening with patients, with communities, with payers. Do you have any reflections on the trends that you're seeing and where you're forecasting us focusing our efforts?
I think three things come to mind. It's a really important question. But one is, I think today relative to say maybe 5-10 years ago, there is a lot of conflict right now within the healthcare delivery system. I don't personally get the sense, maybe it happens, that a health plan leadership team sits down with the local leaders from the hospitals, the physician communities to really have the conversation of how are we going to work together to change care, to improve care, to really think through the roles, responsibilities. And there's a lot of conflict right now that we see through travels, whether it's over prior authorization or how to implement the contracts that get signed every year. But I think we need to work harder, think better for how we build true collaboration systems. Kate, you and I saw that in Arkansas, and I can't see Alicia here, but was just blown away by the work that they are doing to build those collaboration systems. So to Alice's point, I think the future is to really work hard, think better, and I think it's a task for CMS too, is to build those real scalable systems that are building true conversation, true collaboration, to think through how we do the work better. Second thing comes to mind is there is not full agreement, I think, of what is the role of the health plan, what is the role of the hospital system, what is the role of the primary care office, for example. And I think the end result is each is trying to manage the patient, each is trying to bring some care management solution to the patient, with the net result being the patient is confused and the patient doesn't know who's in charge or who is the right person to call to help manage their care. I think as part of that collaboration, we need to agree on what is the role of the health plan. They have certain tools and data that only the health plan can see. What is the role of the hospital system that is managing the acute episode? What is the role of the primary care system that's helping to manage chronic conditions, for example? But that collaboration, conversation, roles, responsibility, I think is still the work to be done. And the third thing I would say is that we need to figure out ways to make the models far less expensive. And if we want to see more physicians, more community health centers work towards these common goals, that we need to work harder to figure out ways to lower their costs. Their time is so stretched right now, and say if we together can figure out ways to bring resources, make it public use, make it public domain, but to really lower the barriers to entry and simplify the language, simplify the purpose, simplify the system, simplify the data collection, then I think we'll be much further along to our goals with those common systems.
Thank you so much, John, and thank you to Alice and to Mark as well. you guys can hear that throughout everybody's remarks, I mean, everybody has their different responsibilities and their different vantage points, but I think what we've done as a group, narrowing in on what's most important. You've heard a lot about simplification through all of our processes. Last year, I think, Alice, we were talking squarely about quality measures, and and it was almost like the data infrastructure pieces were sitting outside of that. And I think now we've really done a nice job of narrowing in on how we can simplify across all of the different elements of payment models in order to really focus on care delivery and focusing on what's most important to patients, which we all know is affordability, access, and experience. So just want to thank you guys for your leadership for the LAN. We're really excited. The next panel that is coming up is a panel of CMS leadership. You'll hear from Liz Fowler, who's the director of the CMS Innovation Center. You'll hear from Meena Sheshmani, who is the director of the Center for Medicare. You will hear from Dora Hughes, who is the director of CCSQ, and Dan Tsai, who is the director of CMCS. And so we're excited for that. And I just want to take a second and say thank you to all of you.
Thank you. Thanks to all of you.